Good evening, my beloved colleagues. For today, this is myself, well known to you almost, I believe. Hopefully, all of you are fine in good health. This is our institute, always welcoming and having pleasure to invite and include you in our discussion to improve our practice as well, not only for the exam. And this is always moral alert. This is our perspective for you. And today, already we declared earlier, the topic will be the recent update in the COPD management. And the great reference till now in the world is the gold. And it is 2025 update we will be discussing. And those who are preparing for the ECT mainly, as well as the OSCE, whenever you will face the question in the exam regarding the management, you need to follow a guideline. And though we usually say that follow the nice guidelines and others, in the world, actually, the no guidelines are contradictory. There might be some difference in a parallel understanding, similar understanding, but not controversial or contradictory, remember. For the exam purpose, though our nice guideline is the priority, but the idea should be what will be the best guideline. And in the current updates, the NICE also sometimes adopting the others guideline. And you can remember in our previous another session with the asthma management updates that there was fantastic changes was there. And NICE authority absorbed the guidelines from other authorities. So there is no confusion. Don't be thinking that we will learn something very different from the NICE guidelines. And these 2025 guidelines, as we will be talking to you, I like to request you whatever you have learned from your learning materials, you can share with us. If any difference or controversy you would find, we can discuss and solve together. For this reason, we are arranging this topic today. Otherwise, suppose the guidelines, even the very recent few years before also over there. And throughout the world, any examination authority wants that our candidate should be very updated with the recent guidelines. And remember, the guidelines is not actually forcing you. It is just guiding you. In your place, you can modify it. And today also you will find where you can modify according to your resources, your feasibility. Even those who attended our topic especially designed for the OSCE candidate as well as ACADE before about the referral knowledge, the setting up of the referral also depends upon the resources available in your locality also. There should have some modification, but for exam purpose, we need to follow a standard guideline. Otherwise, some doctor will answer in one way, another doctor will answer in another way. For this reason, sometimes we sit together and discuss together to make a consensus, to make a uniform decision. So this is the goal already, you know, about the global initiative for chronic obstructive lung disease. So with this few words, now we like to start with the assessment. This is a clinician strategy to assess the disease. We will not be too much in depth of the COPD disease and others. It will be very undergraduate talk. I believe that all of here, those who are attending us, you know about the disease, what is the disease and pathogenesis, other many other things. But for the management purpose, we need to understand some basics that we like to highlight later. For the assessment purpose, just start with this. And in general, you will find that the patient presented mainly with the chronic cough and sometime with the breathlessness. And sometimes we are confused about the diagnosis. What is it actually COPD and the asthma? And definitely you came to know even in your undergraduate life also what is the difference between asthma and COPD. But when you come across a patient with a chronic cough, there are some other diseases can make you puzzled whether it is COPD or not. These are the list. These are the list. So we will not discuss this differential, how to differentiate, but this is the list and you must know about. And all could be a case of your OSCE, remember. All could be a case of OSCE. Apparently you are thinking this is COPD, actually it is not COPD. So take care of this. And in the diagnostic process, you know that we go for the respiratory function test. We say spirometry with reversibility test. And this is the message is how a reversibility test is done. So somebody would say, we will do the peak expiratory flow rate. We discussed a lot about the peak expiratory flow rate and its utility in the asthma patient, not in the COPD, remember it, not in the COPD. So in the COPD, the gold standard test will be spirometry, even in the asthma also. Though there are many other options for the asthma, all of you know, the pheno, many other things, even the bronchoprovocation test. But for the COPD, this is a spirometry with reversibility test. Reversibility done by the bronchodilator. And these are the doses and schedule. As you will not be doing, and you will be walking in a respiratory clinic, you could do. But when you will be sitting in a position of the general practitioners, family physician, actually you will not do. But you should know about the process. Okay. And the findings of the test, you see in the left side, this is the normal trace, FEV1, and these are force vital capacity, and we make a ratio of this. So this is the force vital capacity up to this, because after that lung will not inhale more inside. So this is a plateau, like a plateau appearance. And this is FEV1 in the first, right? In the first second, how much air is expelled and making a ratio. So it is usually done before bronchodilator and after bronchodilator. But the name of the test is a spirometry with reversibility. So to have the information about the reversibility, we need to go for the dual values. Dual values means before bronchodilator and after bronchodilator. But in the COPD, graph will be like this appearance. You see force vital capacity here up to this, okay? And you see the FEV1 here. So force vital capacity here is the 5 liter. Here is the just 3, little above more than here, a little more than 3 liter. Okay. So I believe that you all of know about the tidal volume and other many other thing about the respiratory volumes and capacities. Anyway, to make our understanding simplified, can you follow me, please, how we actually get the interpretation of the spirometry? This is our target. And when we found that this ratio is low, please, as I feel to hear the voice, your glorious voice as a participant in our session. If somebody feel better, you can open the mic, please, and just talk to us. Low means, doctor, actually, what is the low, the ratio? Yes, welcome, Dr. Ihsan. Low means?
It's low, the ratio is lower than 0.7% or 70%.
Yes, yes, very right, very right. Yes, Dr. Hassan, please be with us. Any other colleague, you can feel free also to be with us. If it is low, we will be thinking that it could be what type of disease, Dr. Hassan?
Obstructive disease.
Very right, very right. But before that, to differentiate between the obstructive disease, the COPD is not only the obstructive disease. So it is a common disease, priority disease. Then we will look to the force vital capacity. That is from, it is the only ratio, but we next vision to the force vital capacity. Then if it is the force vital capacity is normal, it is more likely to be obstructive disease. This is the basic thing. This is the basic thing. But forced vital capacity can be low. Can be low. In general, it could be obstructive disease or it could be mixed disease also. Obstructive or mixed. Dr. Ihsan, can you say one mixed disease in this obstructive pattern as well as restrictive pattern could be there? Somehow we discussed before in previous sessions.
I think cases obstructive.
Bronchiectasis. Dr. Piraba, I found. You open the mic, please, to add anything.
Yes, I was about to say bronchiectasis, sir.
Bronchiectasis, fantastic. Because we discussed in the asthma case, maybe the termination of the bronchial asthma, finally going into development of the bronchiectasis, even COPD also going into develop the bronchiectasis. So, if the COPD initially an obstructive disease, in course of time, the later on patient will develop in this mixed pattern. Okay. Now come to the right side. If this normal or high. So normal means normal patient. When will it be normal patient? If there is no other symptom, no other presentation, actually we will not do the test also. It is true. Okay. But in symptomatic patient, these ratio could be normal, remember. Even high. In those situations, again look at the forced vital capacity. And if it is low, this is the possibly restrictive disease. Please, now we like to hear a restrictive disease example. Please.
Fibrosis.
Fibrosis. Enough. There could be restriction in the lung, restriction due to the chest wall, many other causes. So
Interstitial lung diseases.
fantastic interstitial lung disease. So this is the way. And if it is the forced vital capacity is normal or high, then actually this is the normal lung mechanism. So we are dealing might be a disease other than COPD. Clear now? Apparently we are thinking COPD, but if we go with the spirometry and we found the ratio is normal and the forced vital capacity also normal, it is most likely a disease other than COPD. So what other diseases already we have shown to you? Many other causes of chronic cough. Chronic cough. I think you understood this algorithmic presentation. And now come to a solution for our diagnostic formulation. So we already measured pre-bronchodilator, FEV1 ratio and others. Okay. FEV1, you see, pre-bronchodilator, remember, pre-bronchodilator. Okay. FEV1 and the measure this thing. I think it is very simple to understand. After measuring, so initially you see there are two-step recording, pre-bronchodilator and the post-bronchodilator. In the pre-bronchodilator, the ratio is more than 7%. 0.7 means 7%, equal or more than 7%. It is not COPD initially, so it is excluded. Excluded. But patient symptoms are there. Okay. Okay. Then measure post-bronchodilator. You see the line is dotted. A decision up to you. It is not mandatory. FEV1 ratio, if volume responder suspected, that is low FEV1 or high symptoms, this is an very extraordinary clinical situations. I like to advise you, you think that in this setup for your level, not COPD. Now come to this, the algorithm, measure post bronchodilator and then measure the ratio. Then what you are getting? If the ratio less than 7, COPD confirmed. If the ratio is equal or more than 7%, then flow response needs follow-up with repeat assessment. Okay. Repeat assessment means you will give the treatment, or if you're cut by the clinical presentation and then follow up. Okay. So this understanding is very simple. Your question actually will come about from this point, the diagnostic hallmark for obstructive lung disease, 0.7. Even if it is not bronchial asthma, it could, sorry, if not COPD, it could be bronchial asthma also. Okay. So in the bronchial asthma, if clinically we are thinking we need to go for these post bronchodilator response. And when we find that there is a very significant reversibility of the finding, then we will tell this is bronchial asthma. So spirometry can be utilized for the diagnosis of COPD as well as bronchial asthma. From this point of view, come to the gradation of the COPD. It is called the gold gradation. 1, 2, 3, 4. And I can remember there was a question even in the MRCP part 1 also from this value, that when we will say severe COPD or gold stage or sorry, grade 3. So there are 4 categories: mild, moderate, severe, and very severe. Some doctors are confused. Is there actually a very severe category? Yes, in the COPD, there is a very severe category also there. So you need to remember this for exam purpose by this. Okay, by the FEV1, more than 80% predicted. What is the meaning of predicted? Please, can anybody say? Predicted.
Compared to normal individual, I think.
Yes, there is an, according to age and sex, gender, races, whatever, there is set value already set before that this should be the normal value of FEV1 in this population.
Like the growth chart, yeah?
Yes, like this, actually like this, predicted.
Like growth.
But other actual, another word is the actual. Actual means your patient before going to develop the disease, you just measured the respiratory value earlier and made a database for the patient. We in another situation we said baseline. Okay, Dr. Hassan, baseline. Baseline means before going to develop the disease. From there, we are comparing according to the percentage, and then we decide this 30, 50, 80. Try to remember this. Somebody possibly willing to tell, and your audio is not good, doctor. Someone open the mic. I don't know if anybody willing to tell something. Okay, we can proceed. We can proceed. In the assessment part, it's very clinical assessment. You see, we assess the symptom, right? If patient does not have symptom, we will not go for the spirometry. Okay, we will not go for the spirometry. And any disease have the risk factor. This is the basic understanding of development of the disease. So if patient have the symptom and patient have the risk factor for the development of the respiratory illness, these are the factors, very common and important factor. Host factor, tobacco use, occupational exposure, and indoor-outdoor pollution. Very 3, 4, 5 points are there. Then we will go for the spirometry and diagnose, and we will grade this accordingly. So this is the diagnostic pathway for the COPD. And in the OSCE exam, whenever you think of this disease, in your investigation scale, you already remember in the meantime, in the last few weeks, we discussed the different scales for the OSCE. If you don't go for the diagnostic purpose, the name of the investigation, this will be the diagnostic investigation. You will not get the mark for the investigation scale. You could tell, I will measure the blood sugar, I will measure other renal function. Yes, it could be there. It is justified. Even in the COPD, the liver function could be justified. Now, I am mainly asking our COPD colleague, sorry, OSCE colleague today, OSCE aspirant, who can explain me now that when we will test for the liver, but we are suspecting a COPD patient, in which background? Dr.
Alpha 1
Kirama?
antitrypsin.
Fantastic.
Alpha 1.
Alpha 1 antitrypsin deficiency. What will be the expected age of the patient?
Less than 35.
That means younger patient, right?
Yeah.
And what should be the past history? Usually there could be positive Sorry, not past history, rather
Family
family
history.
history. There could be positive family history. So what does it mean now for the OSCE? Now you understand that in a patient during evaluation for the COPD, we must take the family history. Clear? But in general, when patient is elderly in our day-to-day practice, do you think that the alpha-1 antitrypsin deficiency is a common disease, Dr. Piraba or other colleague? Is very common? Not common.
It's
Not common.
uncommon, sir.
For this reason, we are not asking the family history. But whenever a surrogate will tell you that the surrogate's age is 30, 25, you will think that is a tricky station for the COPD. Tricky means if you don't ask the family history, actually your data gathering skill will be poor. Okay. So a little touch given for you for the COPD data gathering. Now come to the next point. Sorry. Regarding the assessment or for a targeted COPD treatment, we need to assess the dyspnea scale. We will not highlight too much, just to give you the principles. In the dyspnea scale, one scale is called modified MRC scale. Modified MRC scale. So it is 0 to 4. 0 to 4. For AKT candidate, you will try to remember what is the grade 2 means, what is the grade 3 means. Each grade must remember for your exam purpose. Up to this, so you will score this from there, 0, 1, 2, 3, 4. Okay. Another one, COPD assessment tool. COPD assessment tool. Here, just asking question and making the scoring. I never cough. I have no flame in my chest at all. This is a very layman term you are using, and asking the patient and marking here. This is 1, this is 2, 3, like this, and make a total score. It is called CAT assessment. CAT assessment. In many where symptomatic analysis, you know about the visual analog scale. Okay, we will utilize just immediately after. For this reason, I am showing it to you. Okay. Next point is exacerbation. You understand that the exacerbation means sudden severe presentation of the disease itself. Exacerbation. Remember that exacerbation could be severe cough, including the breathlessness, but it may not be COPD exacerbation. There might be comorbidity and other. So we will show you also. But in the COPD exacerbation, we will categorize the severity into the mild, moderate, and the severe. Mild, moderate, and the severe. These are the features. May I request anyone what parameters actually we will be seeing here to say there is exacerbation or not? Just to share with me in the discussion, nothing else. Dr. Ihsan or other colleague, please. Just to read only the factors.
Yeah, this is shortness of breath, respiratory
Yes.
rate, heart rate, and oxygen saturation in CRP.
So one is the dyspnea scale, right? Dyspnea scale less than 5 or more than 5. What is the dyspnea scale? Another one, respiratory rate. It may be more or less. I'm asking about the headlines, right? Not the finding. You see, all the headlines are there. Dyspnea, respiratory rate, heart rate, and oxygen, arterial oxygen saturation. Arterial oxygen saturation. So it is an laboratory test, rather to say in our South Asian perspective, be done by the arterial blood gauges. And CRP, another test here, CRP tested in the blood. So considering this thing, we are categorizing the COPD patient in the exacerbation of different severity, mild, moderate, and severe. Okay. Now, how other disease can confuse us about the COPD exacerbation? So we are suspecting exacerbation, but there could be some other differential diagnosis. Common differentials are heart failure, pneumonia, pulmonary embolism, So this actually differential diagnosis at the time of initial presentation, as we are suspecting exacerbation, it could not be exacerbation. That means we need to exclude this by investigation as well. Okay. For example, during the time of exacerbation, why this differential is important, you will come to know later also, but initially I like to give you the hints. During the exacerbation, we may advise steroid. Okay, where is Dr. Ehsan? Please, are you busy again? Be with us,
Yes,
doctor,
sir.
if you don't mind.
Yeah.
Other colleague also. So in the exacerbation, we are supposed to advise steroid. But if there is underlying pneumonia, will it be good option, Dr. Ehsan?
No, sir.
No.
It will decrease the.
Yes, we have to give the antibiotic rather, not the steroid. Okay, steroid can be given as a bronchodilator, the nebulizer and other in the additive treatment, but the priority treatment is antibiotic for pneumonia. Priority treatment for the heart failure will be vasodilators. Vasodilators in a form of diuretics, rather to say. Okay, sorry, better not though. If I say the furosemide, furosemide would have some vasodilator activity. For that, I uttered this word. Rather, I rephrase my word. We have to use diuretics, usually the furosemide, and then you treat it. Okay, but again, we need to remember this thing during exacerbation. These points: dyspnea, respiratory rate, heart rate, and the arterial oxygen saturation, including the CRP. So CRP is a marker of activities. Okay. Now an aggregated assessment chart. This is the latest chart, and just few years rather to say before, this categorization, it is called the assessment purpose. It is not the diagnosis. This is the COPD already we diagnosed before by the spirometry. Now for the management purpose, we are assessing the COPD into to categorize into different groups. So is there any colleague that you know or heard about other type of category before other than these AEB? Just only for my interest. Have you heard that other than this category? This is ABE. Dr. Ehsan? Dr. Gulzar? Yes, please.
Mild, moderate.
Mild, moderate, actually by the gold. There are the grades of the spirometry. According to the spirometry, we are grading. Right? So we are actually, mild, moderate is not the diagnosis. Diagnosis is very simple. What is the diagnostic hallmark? Less than 7% ratio. Okay?
Yes.
Is it, doctor? Sorry, the point 0.7. 0.7 means?
0.7, yes.
Yeah, 0.7 means 70%. Sorry, if I uttered wrong word before, don't mind. Less than 70, the ratio is less than 70%. It is our diagnostic hallmark. If it is the less than 70%, then we were grading COPD into mild, moderate, severe, and very severe. But here, for the management purpose, these gradation, that means the gold gradation is not enough. For the management purpose, we need to consider two other factors. What other factors? Look at and answer me, please. What other factors?
Number of
Heart rate,
time.
heart rate,
No, doctor.
dyspnea.
Sorry. Heart rate, other thing we are considering for the labeling of exacerbations, mild, moderate, or severe exacerbations. That means if you assess this chart, we need to think that not only the grade enough, we have to consider exacerbation history per year. We have to consider the dyspnea. Dyspnea can be assessed by two tools or by two ways. One is the modified MRC scale, another is COPD assessment tool. I think all of you understood. Dr. Piraba or other also, please respond my question.
Yes, sir, I have understood.
Yes,
Thank you.
in the bottom you see the symptoms of the dyspnea, right? Usually dyspnea rather to say. Scale are 2. You can utilize any one. MRC or CAT, anyone. So this is the value, more than 10, less than 10. Here 0 to 1, this is more than 2. In the left side, consider the moderate exacerbation. 2, moderate exacerbation. Below, no exacerbation or 1 moderate exacerbation. Remember the word moderate exacerbation, not the mild. So we need to know how to categorize the mild, moderate, or severe exacerbation, remembering the previous chart. From there, whatever the FEV1, you are thinking the grade 1, 2, 3, 4. But for ABE purpose, after diagnosis of the COPD, considering the exacerbation and the symptoms, especially the dyspnea, so come to a conclusion of A, B, and E. So in the E, you see if more than 2 exacerbation leading to hospital, if there is only 1 exacerbation. So there is a differentiating point is that 2 moderate exacerbation, but they didn't mention about the hospitalization. But moderate exacerbation is 1 point. Another point, that's or equal 1 or more than 1 exacerbation and leads to hospitalization. So main differentiating point in the 1 here above and below is hospitalization. So below there is moderate exacerbation, not leading to hospitalization. But above is 1 exacerbation could be possible in this category E, but it leads to hospitalization. This is the differentiating point. By combination of these, we are categorizing patient into A, E, B. But actually, I asked you, have you heard other than this category? That was just
Earlier it was from A to G, sir.
A to no A, B, C, D, 4 category.
D. Yes.
A, B, C, D. C and D. So C and
Sir,
D means it was here. C
I
here.
one question.
Yes.
So, if we categorize these to A, B, E, and management for the management purpose, so what's the use of this grading system? The gold 1, 2, 3. How they contribute in the management part?
The grades.
Yeah.
Here we will discuss later on, doctor. Wait and see. Wait and see. Wait and see. So we finish only the assessment part here. Now we will come to the management, considering the factors. Okay. COPD management doesn't mean only the management for the bronchodilator therapy. Okay. The grade 1, 2, 3, 4, we need to take this consider into other parts of the management. Dr. Ehsan, as you asked a very nice question, other than bronchodilator therapy, for example, we will tell you LABA, LAMA, steroid, and other. What other actually treatment we have to consider? Just for storming now. Other than this thing? Where Dr. Ehsan? You asked a very nice question, right?
Yeah.
Other than these, LAMA, LABA, or other, we will discuss now. Other than what other management we have to consider?
Steroids, like the drugs you're talking about?
That is a steroid, LABA, LAMA, ICS. These are
Yeah.
the main 3 medication. Other than these, for the treatment of COPD. Pulmonary rehabilitation.
Yeah.
Right?
Pulmonary rehabilitation, smoking.
As well as the vaccination. Isn't it?
Yeah.
So in those grading, there was a graph before also. Possibly I didn't include here. For the grade, wherever the grade 1, 2, 3, 4, we need to consider pulmonary rehabilitation. We need to consider the vaccination, other things. The grade will help in this way. Let's see now. So in the part of the management now, just now we are giving a patient to you. It is a question picked up from your AKT. But again, it could be a scenario after summarization in the OSCE, because it's very common. And I know in the last discussion of the OSCE recall, possibly there was a case in this way. So Dr. Ihsan, please, can you read for us? Just to give me relief for a few seconds, please.
Yeah. 59-year-old chain smoker
Yes.
Complains of breathlessness for 5 months. He has recently been to hospital for pyrometer testing, and these are his post bronchodilator results. FE1 by FVC ratio is equal to 0.65, and FE1 predicted is 57%. A colleague has given him a short-acting muscarinic antagonist, but he has returned because he has persistent breathlessness. What would be the most appropriate next?
So they are asking about the management, but before that, Dr. Isan, please, other colleague, you can open mic, anyone.
Yeah.
Are you convinced that this is a case of COPD?
Yeah.
Sure. Why?
FE1 predicted is there, and FE1 by FVC ratio is 0.6%.
5. This is the diagnostic hallmark. This is the diagnostic hallmark. Now, colleague means you're another colleague where you are the GP. He has given a bronchodilator therapy, right? Initially, short-acting muscarinic antagonist. Can you give one example, Dr. Isan? Short-acting muscarinic.
Ipratropium.
Ipratropium. This is called SAMA, is it?
Sama.
SAMA. So it started with the SAMA, but no improvement. Then what will be the next treatment? Right? This is the question.
Yeah.
This is the AKT question. What will be the next treatment? Please, anyone can respond. Those who are appearing for the AKT immediately. Please, anyone. Dr. Azam, please. Lama. Lama means Lama means that you will continue Sama SOS and you will add Lama, right? Okay. Be with me, Dr. Azam. Be with me.
Yes. But in this case,
yes.
The next step should be like to assess the steroid response.
A steroid response, doctor.
Yeah.
Why you are thinking to give a steroid here?
If there is a steroid response, then we have to add inhaled corticosteroid.
This is okay. This is okay, doctor. Before giving this treatment, muscarinic antagonist or others, so you already assess the patient by the reversibility test before by the bronchodilators. And you are thinking that we could give steroid responsiveness here. You are very right. But before steroid responsiveness, what we have to do? We have to check the eosinophil count.
Yeah, eosinophil count.
That we will be learning here today. Immediately, a little later. But before that, according to symptoms, as we diagnose the case COPD, we are actually having another step to go forward. That what Dr. Azam said is Lama. Can anybody say other than Lama? Somebody would say Laba, right? Yes, very right. Somebody will say Laba. Yes. Okay. Can anybody say something different? It's a very good area to discuss, to know about the difference of current update and the previous update.
Lama plus short-acting, long-acting, Lama and Laba.
Lama and Laba. That means you like to give the combination. ICS also. 3 together.
Laba and Laba are Laba plus ICS.
That means you will give the 3 together. 3 Laba, Lama, ICS.
I have 2 options.
No, sorry, Doctor. Dr. Hasan, choose the best option, only 1, not 2. For AKD exam minimum.
Yeah.
What? Laba plus Lama?
If eosinophil count is less than 300, then I will go for the Lama and Laba.
As eosinophil count not given here, you cannot consider it. Without eosinophil count, what will we do? Actually, we'll switch to the advanced step of the management. There is no doubt. Isn't it? There is no doubt.
Yeah.
So what will be the next step? The AKT colleague, please look at. As your diagnosis is there already, you have done, you have to choose from there. Now, somebody said also the answer they are different. Somebody will say that I will give the steroid, okay? Maintenance oral corticosteroid, somebody inhale corticosteroid. And in the AKT bundle, you will find the answer is long-acting beta agonist. Okay, Dr. Azam?
Yes, sir. Okay.
So you see that your option is not even mentioned also. What is that? Lama, right?
Yes.
But be with us. You answered very fantastically. So what I like to highlight here, as you have the learning material until today also, I think that the answer will be Laba. Okay. But before going the final step, I am asking now the OSCE candidate. Before deciding to step forward for Laba or Lama, whatever, what would you do in these situations? For practical purpose, asking practical question. Especially OSCE candidate, please try to respond.
Yeah, history of asthma, history of atopy, or CBC, if there is eosinophilic count is small.
Okay, for the investigation purpose, you will do a CBC report. Okay, a part of the assessment why patient is not responding. But already you thought that this is COPD initially by the spirometry, isn't it?
Yeah.
By the spirometry, you are thinking this is COPD. Eosinophil will guide us to decide for the further medication, especially with the steroid or not. This is very right. But before switching to the medication or changing the medication, should we check the inhaler technique?
Use, inhaler
Yes.
technique, yes.
Should we check any aggravating factor, especially the triggers, exposure? Isn't it? Exposure,
Yes.
right? Should we check about the status of the smoking? If patient was smoking before, did he or she quit smoking or not? Yes. Isn't it? So there are many other practical issues for the OSCE candidate, remember. If you tell directly in the OSCE station, then I will switch to this medicine, your answer will not be correct. But for the AKT examinee, more likely your answer will be correct. But according to this updated management, your answer will not be perfect. Let's see now how. If this is our the management plan here, what is mentioned here? If you start with the A, you see bronchodilator in the group A, that was 0. That means no exacerbation or one moderate exacerbation. Whatever, if dyspnea scale is here, MRC scale or CAT category, right? Assessment tool, less than 10, then you started with the SAMA, very right. But whenever patient have the symptomatic, where to go now? In the previous history, patient having symptoms, that means symptom is aggravated, right? MRC may be more than 2 or 2. CAT score is 10 or more than 10. Here, your patient is in this group. Now, what will be the treatment? Now everybody can respond. This is the area of our target today for a modified answer. Should we go here or should we go E? Doctor, in our previous patient, I can show you now again to consider our case. I think you can see the font size also. This is our patient. Patient returned because he has persistent breathlessness. No mention of exacerbation, right, Dr. Isan? Because we remember the exacerbation factors were respiratory rate and other heart rate, oxygen, what is that? Arterial oxygen saturation. Isn't that it?
Yes.
So if it is not there, no features of moderate exacerbation, actually patient become only symptomatic. Only symptomatic means patient previously was in this symptom, group A, now shifted to the which symptom?
B.
Group B. So what will be your answer now? LABA plus? LABA plus LAMA. And there is a star mark. So star mark actually for adding of steroid or not. But remember, there will be a combination of the LAMA and LABA. Not single medicine. Dr. Azam and other. Clear now?
Yes, sir.
So this answer is correct now in your question bank. Because we provided the question bank, past medicine authority or other authority provided you to the question bank, right? So this question bank should be modified. Okay, doctor? try to remember, and I hope that after the today's session, you will check it out in your collections. That is this the answer? It will not be an updated correct answer. Okay. Fine. Now, how to summarize the management stepwise? Our first job is diagnosis based on the symptom, risk factors, and the spirometry. If it's the borderline, if you cannot decide, just repeat it after a few days. Then come to the initial assessment. You see, already Dr. Ihsan and other also said, initial assessment includes eosinophil count. Why eosinophil count? To add steroid or not. More likely, there could be reversibility also, wherever the eosinophil count is high, including alpha-1 antitrypsin and other comorbidities. Okay? But for each and every patient, we will not measure alpha-1 antitrypsin, right? Whom we will check alpha-1 antitrypsin, doctor?
Young patient with family
Yes,
history.
young patient, non-smoker with the positive family history. Then we can consider alpha-1 antitrypsin. Otherwise not. But for each and every patient, we will check eosinophil count. We will check smoking status and exacerbation history. Exacerbation will not be very superficial understanding. We already discussed about the parameters for exacerbation. We must check this heart rate, respiratory rate, and others. Then actually we are categorizing the patient into gold ABE. Gold ABE. Okay. Then what will be the initial management? Remember, initial management, smoking cessation, vaccination, active lifestyle and exercise, initial pharmacotherapy, self-management education. Initial pharmacotherapy means whatever we have seen, A, B, E group from their bronchodilators, LABA, LAMA, plus minus steroid. Self-management education like asthma, risk factor management, inhaler technique, breathlessness, that is a symptom, and the written action plan like asthma. Similarly to the asthma, manage comorbidities. These are very basic principles, and these are actually mandatory to say in your OSCE station, because they will not give you the option A, B, C, D, E like this. You have to say everything in the OSCE station. But for AKT exam, this is targeted questions are there from the option you can choose by yourself. Okay. Then review. Okay. After the initial management, you will review the patient in the next time after giving the treatment. In the review time, definitely you will check the technique of the inhaler is good or not. Was there any history of exacerbation? This review maybe after a few months, maybe after 1 year. If patient is okay, usual review is done after 1 year. So exacerbation history, smoking status, patient quitted smoking or not. So other risk factor exposure, inhaler technique already we discussed, physical activity exercise, patient need pulmonary rehabilitation or not. Self-management skill, breathlessness, again written action plan, was patient following or not. Including for the terminal event or severe event, patient does need even the ventilation or not. Vaccination history. History means you advised to take the vaccine before, patient didn't take. Especially happening in the South Asian people for the lack of resources also. Okay. Including the comorbidities, obesity. What comorbidity could happen, doctor, in the COPD patient? Very commonly.
Pulmonal.
Could be heart disease.
Yes,
Because patient is a smoker, right? So this should be considered. This should be considered. And spirometry, patient may come to you at the 3 months, 6 months. If you think we could review the spirometry after 6 months, 4 months, whatever, but it should be minimum 1 time in a year, spirometry. So these are the combination of the management. And according to the finding, we will adjust the treatment. Pharmacological treatment, non-pharmacological treatment, and now can see the overall composite management approach: diagnosis, initial assessment, and initial management. Okay. After the initial management, you can review the patient later on. After the review, you decide, should I adjust the pharmacotherapy or non-pharmacological therapy? So this is very simple, not very complicated one in the management part. In the follow-up time, a broad headline again: review, assess. Ultimately, the same thing: escalate or de-escalate. Escalate, de-escalate means medication increment or medication decrement. Okay.
Decrease.
Again, if you think that patient actually have the trouble to use the device, we'll tell you or show you also what may be different types of device. Suppose very elderly patients, COPD usually elderly patient, they may not use metered dose inhaler well. We have to offer some DPI also, dry powder inhalation. So we have to switch inhaler device. Or the molecule means, suppose we are thinking one type of LABA, patient is not responding, and we understood that inhaler technique is okay. Might be this molecule is not working well for this patient. So we have to choose another LABA, okay, if available there. So this is the molecule. So switch to different device or different molecule. So we can decide from there. Inhaler technique and adherence already we discussed, and the non-pharmacologic approach again, including self-management, education. Now, vaccination for stable COPD. Remember, our first job is to make the patient stable. Okay. So may I request anyone to help me to go through this list, please? Somebody, any new colleague? It is very important, really. Don't push me to read everything for you, please. Can anybody help?
Yes.
Please.
People with COPD should receive all recommended vaccinations in line with the relevant local guidelines. Yearly influenza vaccine, evidence B.
Evidence B, I
SARS,
think you know about the level of the evidence. A, B, C, D, E. A is the best evidence. E is the less important evidence. It is called expert opinion. E means expert opinion. A is the best. There is a statistical category. So B means near about the best. Okay. That means everybody agreed in the world about the influenza vaccination. Okay. This B, right. Then
SARS,
SARS-CoV. Okay.
SARS-CoV-2,
vaccine. Okay.
COVID-19 vaccination based on WHO and CDC updated recommendations, evidence B.
B, right.
Either one dose of
21
21
valent
valent
pneumococcal.
pneumococcal conjugate vaccine, PCV21, or
Yes.
one dose PCV20, as recommended by the CDC, evidence B.
B, right.
Pneumococcal vaccination has been shown to reduce the incidence of community-acquired pneumonia and exacerbation for people with COPD, evidence B.
B. So this evidence is very good evidence, right? B means good evidence. Then
Respiratory syncytial virus,
virus.
RSV vaccination for individual aged more than 60 years or 60 and are with chronic heart or lung disease as recommended by the CDC, evidence A.
Evidence A, right.
Tdap, DTTAP, A vaccination to protect against pertussis, whooping cough
Pertussis.
for people with COPD that were not vaccinated in adolescents as recommended by the CDC, evidence B.
B, thank you, doctor. Next one.
Zoster vaccine to protect against shingles for people with COPD aged more than 50 years as recommended by the CDC, evidence B.
Thank you, doctor. Thank you. Now I am asking you, as you have read, what new information you gathered after reading this? Possibly you know that the influenza vaccine is given in the COPD patient. It's a very old idea, right?
Yes.
Any new idea about the vaccination here after reading this? What other vaccine could be given for COPD?
Pneumococcal.
Pneumococcal also old idea, doctor.
Yeah.
Excellent.
Other than COPD and pneumococcus, what else?
The other code.
Zoster.
Yes, RSV. That is the respiratory syncytial virus vaccine. Then pertussis vaccine. Then zoster vaccine. I think some other advanced candidate also with us. They are excellent. They know earlier. But I think significant number of colleagues today they have heard that about even the zoster vaccine is given for the COPD patient. If I am not wrong, I think I will be happy. This is your benefit. Okay, so this could be considered. Don't think that mandatory. If your country cannot allow this, okay, especially in the South Asian countries, do we imagine that the South Asian government can provide all vaccination for all COPD? What do you think? This is a family medicine doctor.
Yes, sir. I'm family medicine doctor, sir. Here, government not providing, sir.
Yes, we are not providing. Because minimum we can provide influenza and the pneumococcus first. That is the previous thought. Even it is a costly doctor, right? If government
Yes,
is not providing, if you can imagine that even the influenza vaccine, it is not cheaper. It is a costly. Pneumococcal vaccine is costly. Okay.
yes.
So for the practical purpose, considering the resources and the availability, we will advise to the patient. Okay. So this is very, very important. Vaccination in the older people, special topic. Now come to know about the dyspnea and the exacerbation. So slot by that dyspneic patient in the follow-up. So in the dyspneic patient, we consider the LABA or LAMA, anyone, LABA plus LAMA star. Okay, star means actually we are considering with the steroid or not. So if patient have the dyspnea, consider switching inhaler device or molecule. You see, actually, we are repeating the informations, same thing in different stages of the treatment. Implement or escalate non-pharmacologic treatment. Consider adding ensifentrine. Okay. After giving the treatment, patient is still dyspneic. Suppose patient is on LABA or LAMA. You didn't start combination. You start with the LABA as we planned before. Dr. Azam said that we will treat the patient by the LABA. That was our single medicine was the previous thought. Okay. So patient, you have seen, for example, 1 year before. So before learning about the current guideline, you started with the LABA, as you have seen in the AKT question bundle before. Whatever the LAMA also, then you will combine the patient with LABA plus LAMA. After that, patient is still dyspneic. Then you follow this. Okay. The switching inhaler or molecule, implement or escalate non-pharmacologic. That means ask about the environmental and other issues, cigarette smoking. Everything is okay. Now we can consider to add new medicine, ensifentrine. Doctor, who can say what is the ensifentrine? What type of medicine it is? Phosphodiesterase inhibitor. Phosphodiesterase inhibitor help in the dyspneic patient of COPD and investigate and the treat other causes of dyspnea. If you think that in the exacerbation time, patient has increased symptoms, patient having the increased symptom of dyspnea, you could treat other comorbidities also. So this is one stem here. Okay. In the exacerbation time, you see patient may be on the LABA or LAMA, or patient may be in the LABA plus LAMA. Think it here, doctor. Okay. LABA plus LAMA. Now think the practical thing. As we discussed today, the diagnostic pathway and starting the treatment according to ABE. But you patient previously was not treated according to these ABE protocol. Patient may be on LABA or maybe on LAMA previously. Okay. Now patient have the history of exacerbation in the follow-up time. Okay. Then you consider about the eosinophil count. If eosinophil count is more than 300, you are definite to add steroid here. And the treatment, you see, straightforward. It is not LABA plus ICS. It is not LAMA plus ICS. It is LABA plus LAMA plus ICS. Clear?
Yes.
Understand, doctor? So this is that step forward, a rapid step forward management. Okay. But if the patient have eosinophil count less than 300, so they are telling not to add initially steroid. Okay. We have to stop here and consider. If as a physician, if you think that we have to add a steroid, then you can add a steroid. Even the count is less than 300, but more than what? 100.
100.
This is the trap, doctor. Try to remember and memorize. We can use a steroid even in the less than 300, but it should be more than 100. Then LABA, LAMA, ICS. So what is the difference here? Your patient may be in this stage, LABA plus LAMA, then switch to ICS plus ICS if patient is symptomatic. But if your patient in the LABA or LAMA, single medicine, you are straightforward come to the combination of 3 drugs if eosinophil count is 300 or more than 300. Okay. Now another group of the patient, eosinophil less than 100, what will you do? You think that if the eosinophil is less than 100, steroid unlikely to work. Clear now, doctor, from this algorithm? Doctor, who can
Yes.
respond? Unlikely. For this reason, algorithm is following here directly to the another pathway. What is that? To add roflumilast or azithromycin. In which group? Roflumilast and azithromycin for which group of eosinophil count, doctor?
Blood less than 100.
Less than 100, or if it is a 200, can anybody get roflumilast if it is a 200 also?
Yes.
Yes or no?
Yes.
Yes,
Yes.
yes,
It's
yes.
not improved on lab
If
and
it is
lama
if it is following this algorithm, more than 100 but less than 300, patient is on LABA, LAMA, ICS, is still symptomatic, then patient will get roflumilast. But without this steroid, if eosinophil less than 100, if patient is symptomatic, without going to the steroid, we can add roflumilast. So what does it mean? Again, steroid has its limited use in the COPD. Steroid will be utilized minimum one patient should have more than 100 eosinophil, right? Minimum 100 eosinophil. If it is a more than 300 eosinophil, almost certain that we can utilize steroid. So this is the difference between the treatment of the asthma and COPD. So wherever any COPD, and Dr. Isan maybe another colleague also wanted to start the steroid straightforward in the beginning, so it will not be a good decision making. We have to consider these other factors. Okay. If patient have a still symptom after utilizing ICS, that means you are using all 3 weapons, LABA, LAMA, ICS, and eosinophil is more than 300, then what will be the drug of choice next? Monoclonal antibody, dupilumab, monoclonal antibody. And these are mainly chronic bronchitis patient. So somebody use azithromycin, you can see there are some additional parameters or category also. Preferentially in the smokers, azithromycin would work more. Roflumilast would work more if FEV1 less than 50% and the chronic bronchitis patient. This monoclonal antibody, if chronic bronchitis patient. I think it's a little actually attention seeking algorithm. Only listening to my voice today, you may not remember. I advise you after the session, you will remember by writing by yourself, by drawing the diagram or the algorithm. Otherwise, not easy. Okay.
So azithromycin we are not giving. We have heard in AKT that azithromycin we are not giving in smokers.
Sorry, doctor, you could give me the snapshot later and we can discuss. But you see algorithm telling for the smoker, former smoker, doctor, not current smoker. Okay. Former smoker, not current smoker. Maybe you are confused with this. Those who are smoking now, you are not advising azithromycin. Clear? Please go through it again, your notes again. Okay, doctor?
Dose, what is dose for azithromycin?
250 milligram.
Yeah.
There
BD?
maybe there are some dosage schedule may be different. There may be alternate day doses are there. According to the body weight, you can modify it also, isn't it? So for the practical purpose, you can select the dose. But concept is that we can utilize for the azithromycin. Azithromycin actually have some disease modifying activity. Disease modifying activity. If you go through the bronchiectasis management also, many long years before, azithromycin is advocated to prevent the relapse or exacerbation in the bronchiectasis. So it will help to prevent the exacerbation in the COPD patient also. Roflumilast, many years before in the market, but I think most of you didn't use dupilumab. May I ask anyone have experience to use this monoclonal antibody? Doctor? Anyone? I think no, right? I think no.
I think
Usually it will be referred, right? It will be referred and given in the specialist center. And before giving any monoclonal antibody or biologic therapy, you have to prepare the patient in other way. You must give the vaccination because it will create the immunosuppression. There are many other preparations. For this reason, it is not your job. It is the job for a special clinic for the COPD. Okay. So there was some bottom line I like to read for you. To decide, single inhaler therapy must be more convenient. So single inhaler therapy convenient means for the combination therapy also, we will try to advise single inhaler. So convenient and effective than multiple inhaler. Single inhalers improve adherence. Consider de-escalation. De-escalation means you will reduce steroid. Patient is on a steroid, right? For LABA, LAMA plus steroid. When de-escalation of steroid, if pneumonia or other considerable side effects, of the steroid is there, even patient might be Cushingoid after frequent use of steroid. In case of blood eosinophilia more than 300, de-escalation is more likely to be associated with development of exacerbation. This is an alert. That means the 300 count of eosinophil is a hallmark to continue steroid use. Okay. And usually exacerbation means in the last 1 year exacerbation, not in the 1 month. In the 1 year, how many exacerbations happened? Maybe 2 or 3. So this is also important message for you. So overall, this algorithm is as such, doctor. Okay. During the follow-up, you have to consider in the 2 headlines, the further management for the exacerbation and further management for the dyspneic predominant patient. Dyspneic predominant patient. Okay. So this steroid or even the LABA-LAMA, star mark is telling single inhaler in the market available or not, it is up to you. Okay. Doctor, I think you understood. Again, I seek help from any other colleague. Please to go through, doctor, please. Can anyone help? Please, doctor, don't mind to read this.
I will read it, doctor.
Please,
No
doctor,
problem.
welcome. Please, thank you, doctor, please.
Availability of the drug in the device.
Headline is, sorry, doctor, headline is the appropriate inhalation device choice. How to choose the appropriate inhaler for the patient. Please go through one by one.
Okay, doctor.
Yeah.
Availability of the drug in the device. Patient's beliefs.
Availability of the drug in the device, right? What is the available drug in your market in the device in this form? Okay. Then
Patient's beliefs, satisfaction with current and previous devices, and preferences needed to be assessed and considered.
So, doctor, in between, actually, I cannot stop. Don't mind. In between, I have to explain further. Don't mind. Availability of the drug in the device means you selected a device that patient can take well with the DPI. Patient can take the medicine by the MDI. Okay. But is the medicine available in the MDI form in your market? This is the availability. Okay. Second is the belief. Patient have social stigma. This is also another station for your OSCE, that our people, actually younger lady, don't like to use the inhaler. So you have to consider the belief, okay, as well as the satisfaction by using it. Some patient tell the doctor, I don't feel better with this device. Okay. Third point, doctor, the number of
different device types should be minimized for each patient.
Yes. Next.
Device type should not be switched in the absence of clinical justification nor without proper information, education, and medical follow-up.
So be paused, doctor. Device type should not be switched in the absence of justification. Okay. Without clear information, you will not switch. Simply just by assumption, if I switch these, then it will be better. No. Dr. Iram, you raise the hand, please, to say anything. Dr. Iram. Dr. Iram. Dr. Iram, open the mic, please, if you want to say. Dr. Iram telling nothing. So, doctor who is reading, please continue.
Okay. Shared decision making is
Shared decision making. Shared means you and your patient.
is the most appropriate strategy for inhalation device choice.
Right.
Patient's cognition, dexterity, and strength must be taken into account.
That means patient understanding, very simply. Okay.
Yes. Patient's ability to perform the correct specific inhalation maneuver for the device must be assessed.
Right. Now, one by one, you are telling about the different types of device. Please carry on.
Dry powder inhalers are appropriate only if the patient can make a forceful and deep inhalation.
Right.
Check visually that the patient can inhale forcefully through the device. If there is doubt, assess objectively or choose alternative device.
Right. Then MDI.
MDI, metered dose inhalers and to a lesser extent soft inhalers require coordination between device triggering and inhalation, and patients need to be able to perform a slow and deep inhalation. Check visually that the patient can inhale slowly and deeply from the device. If there is doubt, consider adding a spacer, VHC, or choose an alternative device.
That means you know very simply the spacer we are using also, right? Adding a spacer with the MDI rather, right? For the MDI.
Yeah.
Yes. Then
For patients unable to use an MDI with or without spacer or VHC, SMI or DPI, a nebulizer should be considered.
yes. If patient is unable to use this MDI and powder, we have to advise the patient to have an nebulizer at home. Okay. Then next point. Other factors to consider include.
Other factors to consider include size, portability, cost.
Yes, it is very important. Nobody actually like to carry an inhaler device in the pocket, isn't it, doctor? But we are advising that you will take this inhaler SOS, isn't it? Wherever you need, you have to use it. But patient cannot agree. Even if you advise the spacer, doctor, who will like to carry a spacer? A spacer will be an additional device, right? So for this reason, you have to consider. So decision making is not easy. Portability is important. Can they carry or not? Okay. For example, your patient is very showbiz star, right? You understand what I mean? Showbiz person, celebrity. She or he is to dance or sing, and whenever suddenly has the breathlessness, could be. And if he is to take this inhaler in front of many audience, it will be disgusting, isn't it? This may be a topic of discussion in your OSCE station. Fine. Next point, doctor.
Smart inhalers may be useful if there are issues with adherence, persistence, or inhalation technique for devices that can check it.
Okay. Smart inhaler means, doctor, you know there was smartphone. We are thinking smartphone, is not it? There could be some smart inhalers. Extraordinary. And for this reason, companies are now developing very good devices. I think you have seen in your practice time. Very simpler. Yeah. They are telling it is called easy inhaler. There are many other, but according to the guidelines and others, the basic inhalers they are discussing, but more than that, type of inhalers are available in the world also, especially in the rich country. Right. Next point.
Physicians should prescribe only devices they and the other members of the caring team know how
How
to
to
use.
use. Okay. So you as or myself as a physician should prescribe only devices they know. That means you know as well as patient also know. For example, you are telling about some extraordinary smart inhaler you have gone through in the internet and you have seen in the paper or the somewhere, but you don't know. But you are telling, use it, use it. Okay, doctor. Please tell me one story about this. When I was a student, preferably in the clinical years, in my graduation, I can remember there is some gathering. It is called the health camp. I think some of you know about the health camping in the South Asian countries to give the treatment for the poor people in the rural areas. So I was a student. I was not doctor at that time. So I gone with my senior colleagues or the doctor there, and I was thinking patient having asthma, and enthusiastically I was telling that take the inhaler. I remember how much I was foolish at that time. Understand, my colleague doctor? Telling that take this inhaler. Okay? So actually it was not enough to say, only saying take the inhaler, but I didn't know about the inhaler. So same thing can happen in our practice also. So though it was a time consuming slide, and I am grateful doctor who read it out for us for the practical purpose. These messages are very important, especially for the OSCE exam. These are very important. This thing will be a matter of counseling, which device you will advise for your patient. Thank you, doctor. And if possible, another doctor can take the initiative or the same colleague also. Dr. Nadia, can you read
Yes,
this,
yes,
please?
yeah.
Bronchodilators in the stable COPD. Again, bronchodilators. Please continue.
Yes. So inhaled bronchodilators in COPD are central to symptom management and commonly given on a regular basis to prevent or reduce symptoms. Evidence A.
One, evidence A now. Evidence A means the best evidence. It is called, this is the summary of meta-analysis. Meta-analysis. You will learn by yourself what is the meaning of meta-analysis.
Yeah.
That could be a question also in AKT, I know. What is the term meta-analysis? So inhaled bronchodilator is the central treatment. Why this is important? I am observing in my areas now, practice area, patients are getting what is called the aminophylline group. Doctor, another one, what is that? Aminophylline, another one, doxophylline. Doxophylline randomly prescribed, doctor, for the COPD patient, even for the asthma. Okay, because it is tablet form and easy to be taken. But it is not the priority. Priority is inhaled bronchodilator. This is the central treatment. Next point, doctor.
Inhaled bronchodilators are recommended over oral bronchodilators. Evidence A.
Right, not oral salbutamol. Should be inhaler. Next point.
Regular and as needed use of SABA or SAMA improves FEV1 and symptoms. Evidence A.
Very fantastic. So patient could use SABA or SAMA as bronchodilator regularly, or SOS, like asthma, right? Like asthma. But asthma, doctor, what is the difference? SOS medicine now, current? Did you attend our asthma session, doctor, before? Dr. Nadia?
Yes, exactly.
Can
Yes,
you
yes,
remember
doctor.
for SOS
Yes,
treatment, SOS treatment, what was the current treatment now according to the
now
recent
Mart.
guideline?
Mart is recommended
Fantastic,
actually.
fantastic. It is not SABA, SAMA.
Yeah.
MART therapy. MART therapy will be SOS therapy.
Yes,
But
with
for
the
the second
budesonide
line,
and
yes,
formoterol.
for the second line, we would add SABA, SAMA also with the MART therapy. But MART
Yes.
therapy is the first, SOS and continuation therapy, both. So this is the
Yeah.
difference. Because for the COPD, it is not the MART therapy because steroid is not the hallmark for COPD for this reason. Fantastic. Next point.
Combinations of SABA and SAMA are superior compared to either medication alone in improving FEV1 and symptoms. Evidence
Yes.
A.
A. Okay.
LABAs and LAMAs are preferred over short-acting agents except for patients with only occasional dyspnea. Evidence A. and for immediate relief of symptoms in patients already on long-acting bronchodilators for maintenance therapy.
Yes.
LABAs and LAMAs significantly improve lung function, dyspnea, health status, and reduce exacerbation rates. Evidence A.
You see, all are evidence A. So we have to follow it. Next point.
LAMAs have a great effect on exacerbation reduction compared with LABAs. Evidence A.
A.
And decrease hospitalizations. Evidence B.
So in the COPD patient, LAMA have some predominance, right? To take its lead over
Yes.
LABA.
Yeah.
Okay. Then
So, when initiating treatment with long-acting bronchodilators, the preferred choice is a combination of a LABA and a LAMA. In patients with persistent dyspnea on a single long-acting bronchodilator, treatment should be escalated to 2. Evidence A.
A. Sorry, doctor. That was the thing. Your AKT answer was wrong. And we said about the updated management. When initiating the treatment with long-acting, preferred choice is combination, not single. Clear? I
Yeah.
remember Dr. Azam now. Clear, Dr. Azam? When we choose long-acting, it should be better combination. LABA plus LAMA. Okay.
Combination treatment with LABA and LAMA increases FEV1 and reduces symptoms compared to monotherapy. Evidence A.
Same thing we discussed, right? Not the monotherapy. Combination therapy is the preferred. Then
Combination treatment with a LABA and LAMA reduces exacerbations compared to monotherapy. Evidence B.
B. So many symptom exacerbation reduction better with combination. Then
Yes, rather than monotherapy.
yes.
Combination can be given as single inhaler or multiple inhaler treatment. Single inhaler therapy may be more convenient and effective than multiple inhalers.
Okay, we discussed before also. Then ensifentrine.
Ensifentrine. Yes, ensifentrine significantly improves lung function. Evidence A. Dyspnea. Evidence A. And health status. Evidence B.
So when we consider evaluation of the patient, we have to consider about the improvement of the lung function, about the improvement of the dyspnea, about the improvement overall health also. So ensifentrine found it improves all three, but evidence grade is A or B. It is not the matter of your exam. Don't worry. A or B, no need to remember, but only having an understanding that good evidence are there. The last point.
Theophylline exerts a small bronchodilator effect in stable COPD. Evidence A. And that is associated with modest asymptomatic benefits. Evidence B.
B. That means theophylline could be used, no doubt. Okay. Thank you, doctor. Thank you. I think all of you understood. Now, give me a chance to say about the slide. I'm sorry, I am not giving more pressure upon you. Whenever you feel better, you can read. For the steroid choosing, there are some indications. Actually, indication means our decision making. We will be very strong to decide steroid use. That is the ICS. If those green signals are there. What the green? If there is hospitalization history for the exacerbation of COPD previously, if there is 2 or more than 2 moderate exacerbation per year, blood eosinophil count more than 300 or equal, history of or concomitant asthma is there. What does it mean? Without eosinophil count also, if there is exacerbation history, we can utilize steroid. Dr. Isan, are you there? In our previous patient, initially,
Yes,
we are discussing, and you choose that to give the steroid, right? So you were partially right, but that was not exacerbation history, right, doctor? Can you remember? And there was not history of hospitalization. Okay. Yes. If you think that at that time I would check eosinophil count and found more than 300, right? On that patient also, you could add steroid, but not single steroid. It should be LABA, LAMA plus steroid. I think you can modify now your answer, right? Correctly. So these are the green signal for steroid use. Now, the brown signal or yellow signal, rather to say, one moderate exacerbation. Here is 2 exacerbation. Here, 1 exacerbation per year. Blood eosinophil count 100 to 300. Already we discussed before that. Within this range of eosinophil count also, patient may take steroid. So it can favor the use. But the red signal, we will not advise steroid in the COPD patient if patient have repeated pneumonia, patient have less than 100 eosinophil, and history of mycobacterial infection is very important for the South Asian patients. Tuberculosis. Okay, doctor? So steroid use, I think you can have an guidelines or guidance for you. Okay. And next point, that is the bottom line. Despite appropriate long-acting bronchodilators maintenance therapy, the figure 3.73 for the recommendations. So this is another, sorry. The note that blood eosinophil should be seen as a continuum. Continuum means only one reading is not enough. You have to check follow up also. There's eosinophil actually may fluctuate up and down. So you have to follow up with the eosinophil count also. In future, if there is exacerbation, but there may not be high eosinophil count, it could be there. So it is not the fix that today eosinophil count will be the same after 1 week. So check it repeatedly. Okay. And this is a Venn diagram. In our COPD patient, there could be component of asthma. In the COPD patient, there will be component of bronchiectasis. Okay. If COPD combined with the bronchiectasis, it will be termed as B cause. If COPD combined with the asthma feature, that means the more reversibility, it will be A cause. I think some of you have heard it. What is the meaning of A cause, doctor? Please, quickly, anyone can say A cause means? A cause? Asthma COPD overlap syndrome. This is a terminology. So what we discussed about ACOS before, that means we selected COPD patient who will get benefit by the steroid. Actually, it will be labeled as asthma COPD overlap syndrome. If you found that, there is a very good responsibility, though patient is diagnosed as COPD, smoker and other elderly patient, but there is significant reversibility. We can label the patient as asthma COPD overlap. Nowadays, it is called asthma COPD overlap, echo. But recent past, it was termed as ACOS. Similarly, BCOS, bronchiectasis, COPD overlap syndrome. Again, you see, asthma can be combined with the bronchiectasis. That we told before. COPD will terminate into bronchiectasis. Asthma also will terminate into bronchiectasis. So now you understand, doctor, who someone answered very nicely. By the spirometry, the mixed picture will be found in which box, doctor? The red box, green box, or what is that? I like to say light green, the bottom one. The mixed picture in the spirometry. In which box? In this box. Because bronchiectasis, the mixed picture you can get there. That means there could be COPD or there could be asthma in combination with the bronchiectasis. Right. Okay, doctor, we are taking a little long time because there are many texts, doctor, and thankful again to you that you have taken the opportunity to help me. Now, in the previous guidelines or previous treatment protocol, you advise the patient with LABA plus ICS, right? Like the asthma device. And in the market, still now, the devices are available, steroid with the LABA. So patient is on these, but your diagnosis is COPD. Now what will you do? That follow the patient up. Patient currently on these, because LAMA will take the preference. Already we decided. LAMA will take the preference for COPD patient. So there will be every effort to advise LAMA in addition. How we are going to add LAMA here, you see? If no current exacerbation and the previous positive treatment response was there. Patient, you see this star mark, patient previously had exacerbation but responded to LABA ICS. Responded to LABA ICS. In those situations, patient does not have the symptom, then only you continue the same treatment, LABA and ICS. But patient having high symptom despite no exacerbation and the previous positive treatment for the response. That means response for the exacerbation. There is good response, but symptom is high now currently. Then consider to escalating to LABA, LAMA and ICS. You see, the core concept is to add the LAMA. I repeat, core concept is to add the LAMA in the COPD patient. Sorry, second group, no relevant exacerbation. No relevant exacerbation was there. Then change to LABA plus LAMA, not steroid, because steroid will create the side effect. Then come to the right side, current exacerbation. So we are dividing patient into three groups. One is the current exacerbation. Left side is the no current exacerbation, but previous exacerbation was responded. In the middle group, no relevant exacerbation history, not at all. So in the third one, if exacerbation is there, currently patient came to you with recent history of exacerbation. Patient is on a steroid still, LABA plus ICS. Then check eosinophil count. Already we told you eosinophil count actually is fluctuating. Now today you check. If you found eosinophil is less than 100, so remove steroid from there and add LAMA. Clear, doctor? Please, someone respond to me if you can hear. If eosinophil is less than 100, that means you are thinking, you thought or you understand steroid is not actually useful here as eosinophil count is less. Again, there is exacerbation. Eosinophil count is more than 100. Patient LABA and ICS. Then add LAMA. So you see, eosinophil count is less than 100, you are adding LAMA. Eosinophil count is more than 100, also you are adding LAMA, including steroid. So everywhere, every target is to add LAMA in your current patient. Okay. I will be happy for your proper understanding. Now, we are using other medication for the COPD patient. What is the evidence here? If alpha-1 antitrypsin deficiency is there, then, okay, it will be useful for slow down the progression of emphysema, evidence B. Antitussive, doctor, evidence C only. That means the cough suppressant and evidence C. But randomly patient getting the medicine from the pharmacy. So by the evidence, you know the evidence-based medicine is important for your OSCE management. So be careful about telling this. Vasodilators, no improvement outcome. No improvement outcome and worsen oxygenation. So it is a bad. This evidence B. That means the negative information is evidence B. It is not in favor of evidence B. It is not to use evidence B. Opioid may be helpful. Low dose long-acting oral or parenteral opioid may be considered for the treatment of COPD for the dyspneic patient. Evidence B. And the pulmonary hypertension therapy. This is another area of abuse. Primary pulmonary hypertension and secondary pulmonary hypertension. In the COPD, if pulmonary hypertension develop, it will be secondary pulmonary hypertension. So, the bosentan you know about, right? Bosentan. This bosentan, ambrisentan used for the primary pulmonary hypertension. So, drugs approved for the primary pulmonary hypertension are not recommended for the patient with pulmonary hypertension secondary to COPD. Be careful about that. Okay. Non-pharmacologic treatment, doctor, look at the right side. Already we group the patient into A, B and E. B and E. In the non-pharmacologic treatment, non-pharmacology means treatment by LAMA, LAMA, ICS. These 3 pharmacologic treatment for COPD, but it doesn't mean the non-drug. Remember, non-pharmacology doesn't mean non-drug at all. You can use drug for other purpose. For example, you are giving the vaccination. It is also drug. So it will be contradictory if you say that non-pharmacology means non-drug. So in the non-pharmacologic treatment, wherever the stage or grouping A, B, E, these are common: influenza, COVID, pneumococcal vaccine, pertussis vaccine, shingle vaccine, and respiratory syncytial virus vaccine. This is for your theoretical purpose, including the physical activities for each and every patient. Okay, but for the pulmonary rehabilitation, smoking cessation, pulmonary rehabilitation, especially pulmonary rehabilitation, useful for the group B and E, not in the initial step. Okay, this is the difference. And follow-up patient doctor for the pharmacologic treatment. I am just showing you some slides and few minutes, be with me. In the follow-up, we are thinking patient responding initial treatment. So maintain it. Maintain the pharmacologic treatment, non-pharmacologic, the other managements, and offer influenza vaccine if not taken, education and assessment, behavior, risk factor, smoking, and other all things. Ensure maintenance of exercise program and physical activity, adequate sleep, and healthy diet. The traditional things. But patient is not getting the benefit. Consider the predominant treatable trait. Identify where is the mistake. For the dyspnea, these are the things. For the dyspnea exacerbation, about the non-pharmacologic treatment, we will provide the list, doctor. We don't like to keep you more today, and no need to read it also. We will provide the slide later on if possible. And if response to initial treatment is appropriate and maintain it, offer another. This is a common slide. We will provide this slide for you in the group. If needed, you can get it, doctor. The last few words about the terminal care or the advanced care. Long-term oxygen therapy. Again, it is a matter of question in AKT as well as the OSCE, LTOT. It is usually taken for the 16 hours in a day. Patient is to carry this bag, oxygen cylinder like this, with an oxygen, you see, prawns or something to be put. So you need to convince the patient for use. And when we will actually consider the LTOT and how to follow up. So if the arterial oxygen, partial pressure of the arterial oxygen is less than 55, okay, or saturation is less than 88, or this way, this is the category, okay, and it may not be your exam because it is difficult to remember in your exam. So just to have an idea, if hypoxemia is there, so we will advise supplemental oxygen to keep the oxygen level, oxygen saturation more than 90%. What is the advantage of this? I am asking you, doctor, especially OSCE candidate. What is the advantage of giving low dose oxygen in this COPD patient? Doctor, anyone? Please, anyone can respond if you advanced. Low dose oxygen prevent the development of polycythemia. Patient will get some symptomatic relief, but as well as polycythemia. Hypoxia is a stimulus for polycythemia. Patient will develop complication of the polycythemia in course of time. So it is useful for the COPD patient. Okay. Then recheck after 2 or 3 months about the oxygen utilization if patient needs any technical support. Remember, doctor. Now show you very swiftly, doctor, different types of devices and the inhalers. Just with me, few of them, we will not discuss too much. These are the abbreviations, doctor, of the mnemonic, the legends use DPI, SMI also. SMI means soft mist inhaler, different types of device. Just quickly be with me. These are the drugs available in the market. Beta agonist, long acting LABA. These are nebulizer form, some are oral and injectable form. So message for you that all devices are not containing all types of medicine. This is the message for you. So you have to know about which medicine available in which devices in your market. Again, the duration of action, 12 hours, 24 hour. So long acting have 12 hour and 24 hour. But beta to short acting drug variable action, it may be 2 hour or 1 hour. It is not fixed. Okay, right. And then the next slide, doctor, the anticholinergic Sama and Lama. Be oriented with the name only. Again, different devices are there. Okay. Oral and injectable are not available of this thing. Again, the duration of action. Okay. Then again, the combination short-acting beta agonist plus anticholinergic, that is Saba and Sama combined drugs are available. So you have to remember which is short-acting Sama and which one is the Lama. Lama is the tiotropium and the short-acting is ipratropium. Okay, this is ipratropium is short-acting. Okay, then you see in the LABA, another term you have to remember, it is called rapidly acting, long-acting. You see, rapidly acting, long-acting. For example, formoterol. This is the hallmark treatment now for the asthma patient. MARD therapy, formoterol based, including glycopyrrolinium. Usually glycopyrrolinium advocated for the COPD patient. These are the other name of the LAMA, including beta long-acting beta agonist. Formoterol and this one, formoterol and this one. Okay, vilanterol is available. Okay, and methylxanthine, aminophylline, theophylline. So these are oral or injectable delivery, not nebulized form. Okay, doxyphylline and others. Combination. These are just market name, doctor. Better to switch. Better to switch. Triple therapy available usually for the COPD, LABA, LAMA, ICS. Now you came to know that single inhaler device is important for the compliance of the patient. It is available in the market. It is called triotherapy. Triotherapy. This combination by the DPI as well as MDI. 24-hour, 12-hour like this acting. That the phosphodiesterase inhibitor, roflumilast or ensifentrine tablet and others. Already we discussed indication for the patient. Okay. Mucolytic agent to liquefy the secretions. These are also used. Okay, carbocystine and acetylcysteine. So ardocysteine capsule, nebulizer, and acetylcysteine available as nebulizer form also. Okay, you can utilize that monoclonal antibody. It is available in the injection. Usually supervised treatment is given. So these all, doctor, for your COPD medication is that list actually be divided for you for better presentation. And lastly, the follow-up patient checklist be given, and you have to know about the follow-up information by giving a written instruction and the follow-up sheet to the patient. So just few word about the exacerbation rapidly. Already we discussed, categorize the exacerbation, and these are the differential diagnosis and differentials of these, how to exclude by the investigation. Differential diagnosis could be pneumonia, pulmonary embolism, heart failure, pneumothorax effusions, even the myocardial infarction also. Be careful about that. Don't think all symptoms are exacerbation. These are most frequent, commonly found and in our clinical practice. So treat this accordingly, and potential indication for the hospitalization assessment. But we will provide the slide, doctor. Please, someone request us in the group so that we shouldn't forget. That means you will, for the OSCE candidate, must remember it. You will send the patient for hospitalization, but considering the resources available or not. Local resource need to be considered. Then you can say hospitalized assessment. Nowadays, one term is available, especially in the Western world. It is called hospital at home. I don't know, have you heard or not? HAH, hospital at home. That means some activities usually done in the hospital can be done at home if facilities are available for the COPD patient especially. So local resources are important if the conditions are there. Long, not life-threatening exacerbations. Severe but not life-threatening. Okay, you can utilize antibiotic. You can consider oral corticosteroid also for the exacerbation. Consider antibiotic when signs of bacterial infections are present. So by your clinical assessment, you can use antibiotic also. Okay, but even there may be pneumonia on recovery. It is not absolutely contraindicated. You can use some low doses of steroid also there. It depends upon you. But check other things. Okay. And if again resources are not available in as a GP center or other, you just send patient to the advanced center for this exacerbation therapy. And the key point of the management for exacerbation, actually, we don't like to utilize more time today. Again, according to the evidence, because I think that in South Asian countries, GPs are not very obliged or have the opportunity to treat the exacerbation at your GP center. In general, for the practical purpose, in South Asian context, my humble suggestion, do something and refer. We discussed before also, do and refer. You cannot complete your management. For this reason, I am not highlighting and explaining too much. But according to the gold guideline, where the facilities are there, you can manage for the exacerbation, non-severe exacerbation. Okay. I think lastly, again, indication for the ventilation. It is not in your hand. For the management purpose, emergency, we discussed before the referral. Emergency referral. If it is emergency referral, we have to consider the indication for the emergency referral in the COPD, and these are the things, especially pH and other. I believe our South Asian people even does not have the facilities for ABG. And anybody can say that who are having ABG facilities in the GP center, those who are attending. I think most of you don't have. Okay, most of you don't have. So I think we can conclude the discussion for today, doctor, in this way. As near about many more minutes we passed, I think that you might be reluctant to ask me any question, but those who are enthusiastic and considering to contribute to this discussion, if anything missed, doctor, you can open the mic and comment or even ask me. I will try my best, doctor, to answer. Anyone here, doctor? Anyone? I think no. So our heart, Dr. Azam, please. Yeah, doctor. Yeah, Dr. Azam, please.
Ensifentrine, sir, explain kar, please.
Oh, this is phosphodiesterase inhibitor, doctor, like roflumilast. Phosphodiesterase inhibitor, combined phosphodiesterase inhibitor, it help in the COPD. But we already gone through the algorithm. Which type of phosphodiesterase inhibitor will be utilized in the chronic bronchitis group? Okay, we utilize the roflumilast. Okay, we use roflumilast, and ensifentrine we utilize for that one less than eosinophil count less than 100. So far I can remember the algorithm. Okay, Dr. Azam?
Okay, sir.
I think it is a new drug, right? You have heard today. I think so. Is it, doctor? New name. Roflumilast was available in the market before. With these few words and showing our heartiest gratitude to you, we like to conclude, doctor.